I will start now. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good morning to thank you all for coming to our colloquium. So today it's going to be a slightly different format of talk. The MC and also the speaker. So I will start the talk straight away for about 30 to 45 minutes. And then we have about 15 minutes for question and answer. Okay, I will show you my screen. Can you see my slides?
Yes.
Okay, thank you. Thank you for your response. So my name is Ahmad Mahfuz bin Ghazali. So I'm a faculty member or researcher under Industrial Biotechnology program. Under Faculty of Industrial Sciences and Technology. So today I'll be talking to you about my research. The title of my talk is and research training. I started my bachelor degree in biomedical science at IUM until 2008. After that, I completed my postgraduate study in immunology at King's College in master and also in PhD. After that, I undergo the field of immunology and so on the bottom right corner, on my right, you can see all my ID, social media ID. So if you can't remember all of this, you can just type my full name and you can find me on all social media platforms.
Sorry, Dr. Mahfuz. Interrupt sekejap. There is postgraduate student who would like to join the session, but it need to get approved to enter the session.
Yes, Encik Halimi is now doing that. He's allowing a postgraduate student to enter.
Okay, thank you. Sorry.
Okay, so the outline of my talk today, so I will give introduction about type 1 diabetes, and then we'll talk about natural history or the disease cause. We'll talk a bit about the pathology of type 1 diabetes, followed by antigen-specific cells in type 1 diabetes, diabetes-associated autoantibodies, then alteration to T and B cells, and finally type 1 diabetes in Malaysia. Okay, what is type 1 diabetes? It is a chronic condition caused by immune cell infiltration and destruction of insulin-producing beta cells of the pancreas. So basically, insulin is an important hormone for us because it helps to convert the sugar into glucose, and it will instruct the cells to uptake the glucose. So what happens in type 1 diabetes is normally when you have immune cell infiltration, this immune cell will attack beta cells and cause the death of beta cells. So your blood sugar will stay in higher concentration in the circulation or in the blood. Why this is very important? This is very important because when you have uncontrolled blood sugar, it will lead to serious complications such as diabetic ketoacidosis, hypoglycemia, vascular and cardiovascular complications. So diabetic ketoacidosis is a condition where your body will convert your fat storage into ketone. So why ketone is dangerous? Ketone is dangerous because it will make your blood become more acidic, and this condition can lead to death. In the meantime, one of the complications of uncontrolled blood sugar or type 1 diabetes is you can get hypoglycemia or low blood sugar. So the mechanism how it happens is quite complex, but I will not touch it here. And also, type 1 diabetes can cause complication to your vascular or your blood vessel and cardiovascular, which is your heart. So you often see that people with uncontrolled diabetes, they may have cardiovascular disease or cardiovascular complication. And currently, the only available treatment is by administration of insulin. Therefore, early diagnosis and treatment is important to avoid any complication. So what happened in type 1 diabetes, as you can see from my left, you have a healthy pancreas here. So healthy pancreas will produce insulin. So insulin will convert sugar into glucose, and this glucose will be uptake by the cells. Whereas in diabetic patients, their pancreas are being infiltrated by immune cell, and the consequence of this is the beta cells are destroyed because of the attack of immune cell. So when you no longer produce insulin, you have higher concentration of glucose in the blood, and your cells will not receive the glucose. That's why you get hypoglycemia. So on my right, so you can see there's a case report. This is reported in the late 19th century, and this was published 2 years ago in Lancet. So there was a girl, so you have a girl that suffers from type 1 diabetes. You can see that she is very thin and skinny, and after 4 months of insulin treatment, her condition significantly improved. And because of the discovery of insulin, the researcher, Frederick Grant Banting, won Nobel Prize of Medicine in 1936 because of his discovery of the importance of insulin. So as I mentioned, insulin administration as a treatment is used to replace endogenous insulin, not to stop the destruction of the pancreas. So when we administer insulin to this patient, it's simply to replace or substitute the insulin that is not being produced by the body. So why do we say type 1 diabetes is an autoimmune disease? Autoimmune disease refers to disease where your immune cells attack your own body or your own cells or organs. There are several evidence that suggest or that support this theory that type 1 diabetes is an autoimmune disease. However, for the sake of this talk and time, I will only discuss with you all these 4 different evidence. So firstly, we have islet autoantibody. So islet is a compartment where beta cells are located in the pancreas. So one of the signs that a patient has type 1 diabetes is when you can find islet autoantibody in their blood or in their circulation. Secondly, you have also a strong HLA class 2 association. So HLA class 2 molecules present on antigen-presenting cells. This molecule can present antigen to activate immune cells. Also, 2 more evidence that support the theory or hypothesis that type 1 diabetes is an autoimmune disease. Firstly, you can find T cells, or one of the immune cell subset that are specific towards what we call it beta cells in patients. And finally, there are so many genes associated with the disease, immune-related genes. So as I mentioned, the strong HLA2 association, nearly 90% of Scandinavian type 1 diabetes patients display HLA DR3, DR2, and HLA DR4, DR8 haplotype alone or in combination. So Scandinavian here refers to Denmark, Norway, and also Sweden. So in this Scandinavian patient, almost all of them display these HLA molecules. In addition, as I mentioned before, most of the genes associated with the disease or susceptible with the disease, as you can see here, there are several genes. Firstly, you can see example of PN22, where the odds ratio is 1.9. So this means that people with this mutation have 1.9% risk, 1.9 more risk compared to normal person. So you have other immune-associated genes such as interleukin-10. You also have STAT4, CTLA4, CCR5, and so on and so forth. So these are the two first evidence that support or suggest type 1 diabetes is an autoimmune disease. I will talk now about the natural history or how the disease developed in humans. So first we have a graph where the y-axis represents the beta cell mass. So these are the cells that produce insulin. And in the x-axis, you have time. So normally, when you have both genetic and environmental factor in a healthy individual, then this disease can start. So we have, firstly, the stage, what we call as pre-symptomatic type 1 diabetes. So in this stage, you already start to have diabetes-associated autoantibody, and the immune cell already start to attack the beta cell and destroy them. And this process continues to happen until you have about 30 or 35% or to 40% of beta cell mass left. So when this happens, then you no longer have insulin being produced by beta cell, and you start to have a disease in which you have higher blood glucose in your circulation. And fortunately, scientists can now predict the diagnosis way before the disease starts by looking at the presence of diabetes-associated autoantibody. Okay, so how actually the disease happened, or the immune mechanism or immune pathology of this disease? Okay, this is a bit complicated, but I will explain to you. So firstly, after birth, what happened is you have in the thymus, you have antigen-presenting cells presenting peptide to regulatory T cell. So this is important process because you want to induce tolerance. However, in type 1 diabetes patient, this does not occur. So when this does not occur, what happens is antigen-presenting cell will interact with autoreactive T cell to activate immune response. This is happening in thymus. After this, the CD4 T cell will migrate to the pancreatic lymph node and activate beta B cells. So B cells will differentiate into plasma cells and produce autoantibodies. In the meantime, CD4 T cell can travel to and also activate CD8 positive T cell, CD8 positive T cell. And CD8 positive T cell will attack and cause the death of beta cells. So I have briefly talked to you about the how this disease happened. So another evidence or mechanism that supports the theory why this disease is an autoimmune disease is because they have the presence of antigen-specific cells. So this slide, I just want to show you different methods that you can use to detect antigen-specific cells from type 1 diabetes patient. I will not go into the detail, but I'm more than happy to answer about the method. So as I mentioned before, another evidence that support or suggests that type 1 diabetes is an autoimmune disease is we can find antigen-specific cells in type 1 diabetes. So as you can see here, we can find examples of papers that report the presence of CD8 positive cells that are specific towards what you call it, insulin or towards antigen in the pancreas. And we can also find examples of CD4 T cells that are reactive towards antigens in the pancreas. More importantly, this last paper showed the presence of both CD4 and CD8 cells either in the pancreas or in the blood of type 1 diabetes patient. The last evidence that support this theory that type 1 diabetes is an autoimmune disease is the presence of autoantibodies. So basically, you can categorize this autoantibody into two categories, non-biochemical and biochemical antibodies. So you have the name islet cell antigen autoantibody ICA, and also biochemical autoantibodies. You have 4 of them here: insulin, insulinoma associated protein 2, glutamic acid decarboxylase, and zinc transporter 8 autoantibody. So the difference in biochemical and non-biochemical antibody is biochemical antibodies have higher specificity and compared to non-biochemical autoantibody. So in type 1 diabetes, or before the development of the disease, you can use autoantibodies to predict the disease. So, okay, to my left, as you can see here, when you have only ICA, when the children is at the age of 5 years old, about 20% of them develop type 1 diabetes. But when we have more than one autoantibodies, at the age of 8, about 80% of them will develop type 1 diabetes. Another study also reproduced the similar finding. As you can see here, if you only have one islet autoantibody, by the age of 15, only about 10% of them develop type 1 diabetes. Whereas when you have more than one autoantibodies, by the age of 16 to 18, about 60 to 80% of them will develop type 1 diabetes. So from this predictive power of autoantibody, is also combine it with the genetic factor, and they have categorized the risk of one or healthy children developing type 1 diabetes based on autoantibody profile and also genetic susceptibility. So here you can see in the y-axis, if you have 4 islet autoantibody, if you have HLA risk genotype, you have 80% risk of developing type 1 diabetes. Okay, now we're going to move to the so-called research part. Just now I just mainly touched on the clinical part. Why we move on the research part? Because autoantibodies or antibodies and antigen-specific cells are used by basic component or basic immune cells, which are B and T cells. So firstly, I will talk about B cell, which is the most important cell in producing autoantibodies. So here is the simplified version of how B cell works. So basically, you bind to an antigen, it will receive a chemical signal from helper T cell, and it will differentiate to become plasma cell and then produce autoantibody. This is the simplified version of the function of B cell. However, when we look at the development of B cell, it develops in bone marrow and continues maturation in the tonsil before becoming plasma cells. So in type 1 diabetes, people have looked at B cells either from peripheral blood or in the pancreas. So this is the research published by my whole research group in Finland. So they have showed that there's no difference or changes in B cell compartment in type 1 diabetes patient. A similar study is also being produced by another group from the UK. So they show that there's no changes in the B cell compartment in type 1 diabetes. However, another group in the US showed that there might be changes in type 1 diabetes related to the genetic factor PTPN22. So the same group, this second paper, they also looked at B cell expression in the pancreas of the patient, and they can categorize the patient by having either higher B cell or lower B cell in the pancreas. So we don't know how it might affect the outcome or the prognosis of the disease yet. So I mentioned before this that B cell require T cell to help them to produce antibodies. So here there are a lot of subset of T cell. So basically, when you have antigen presenting cells presenting antigen to T cell or T helper cell, it will differentiate to different type of T cell based on the environment. But in this talk, I will only focus on regulatory T cell and also follicular T helper cell. So firstly, we want to look at the follicular T helper cell. This is an important cell because it produces chemical signal to help B cell to produce antibodies. So in type 1 diabetes patient, it has been reported that the frequency of these cells are increased. So these first two papers are research published by my old group in Finland. So they have shown that these cells are increased in the type 1 diabetes patient, suggesting that they might have important role in the disease. Other research groups also have found similar studies where they can find higher proportion or percentage of follicular T helper cell in type 1 diabetes patient, and also higher secretion of chemical signal that can help B cell to produce antibodies, which is, in this case, it's interleukin-21. So now we have looked into the follicular T helper cell. We wanted to look into regulatory T cell. So this is a very important cell and very close to my heart, these cells, because I did my PhD study on these cells. So this regulatory T cell, they have basically two functions. Firstly, they will suppress T cell proliferation, and they will also inactivate antigen-presenting cells. So in type 1 diabetes patient, you can find defective T cell function. But firstly, we reported that the composition of regulatory T cell are altered in type 1 diabetes patient. And also other group reported that these T cells function are impaired in type 1 diabetes patients from peripheral blood. And similarly, another study reported that the regulatory T cell function is impaired in type 1 diabetes, and these cells are taken from the pancreas of the type 1 diabetes patients. So, as I have mentioned before, that one of the function of regulatory T cell is to suppress T cell proliferation. So we also look at the T cell proliferation in type 1 diabetes patient, and we can see that these T cells have capacity to resist suppression from regulatory T cell. This is earlier study published by the UK group, and this is what we published recently, where we show that this mechanism of resistance is linked to the STAT3 molecule. Okay. You the knowledge of type 1 diabetes in general, and now I want to shift gear to the last part of my presentation, which is to look or to study type 1 diabetes in Malaysia. So epidemiology of type 1 diabetes in Malaysia, which refers to the statistics. So here you can see from this world map, the International Diabetes Foundation said or estimated that less than 1.5 in 100,000 children in Malaysia are affected by type 1 diabetes. However, we cannot verify this exact figure because the diabetes in adolescent and children registry couldn't make an estimate of the incidence rate. But the worrying trend is more than 70% of diabetes cases in Malaysia reported in adolescent and children. So basically, these are people under the age of 18 years old. Most of them, or more than 70%, are type 1 diabetes patients. Again, why I want to study type 1 diabetes in Malaysia? Globally, the incidence of type 1 diabetes has increased worldwide for the past decades. And this increase has been postulated to be caused by environmental factors rather than genetic factors. And most of the information that you will obtain that I have shown to you are derived from individuals of European descent. So it means that the data that we got about this disease are studies from population from Europe or from Australia or from USA, but not so much from Asia. And then, most importantly, children of low socioeconomic background are commonly affected by diabetic ketoacidosis, which is a life-threatening condition. And in today's term, we call this as children of B40 group. As I mentioned, just want to show you that now in the early 21st century, more and more cases of type 1 diabetes are caused by environmental factors rather than genetic factors. So these are preliminary studies that I performed based on the data that we obtained from our collaborator in IMR. So firstly, I wanted to make a comparison of autoantibody. And the reason why I choose Finland is because it has one of the highest incidence rate of type 1 diabetes in children. So 60 in 100,000 children in Finland has type 1 diabetes. And I am lucky to be able to study this disease in Finland. So we want to make comparison between Finland and Malaysia. So the first comparison is we want to look at autoantibody profile at diagnosis. So before we make comparison, it is worth to note that in European population, normally you have two sort of groups of patients. So you have firstly patients that normally have insulin autoantibody that appear first, or you have GADA autoantibody that appear first. And these two groups have sort of different risk factor and environmental factors associated with it. So firstly, we wanted to compare the number of autoantibodies present. So as you can see in Finland, in Finnish patient, most of the antibody that you can see are from the children or cases with 3 autoantibodies. But in Malaysia, data from 2006 and 2018, so this is preliminary data. We are in the process of verifying this data and trying to publish this as soon as possible. In Malaysia, we find that most of the cases only have 1 autoantibody. And then when we look at all the antibodies, autoantibodies, at diagnosis, children from Finland normally have IA2A autoantibody, but children from Malaysia strikingly have GADA as the major or main autoantibody at diagnosis. And we also look at detailed autoantibody profile. As I mentioned, children from Finland in 2017, they reported most of them have mainly 4 autoantibodies, but children in Malaysia, they only have maybe 1 or 2 autoantibodies. And this is dominantly GADA autoantibody. So that's a preliminary analysis that I have performed, and I hope to get more funding to study detailed mechanism of type 1 diabetes from Malaysian patient. So firstly, it is an autoimmune disease despite the sign and symptom arise because of the lack of insulin. We can find antigen-specific cell in the blood and pancreas, but it's very difficult to detect these cells because when you look at the frequency of these cells, normally you can get between 1 or 2 cells per 1 million PBMC. So it's very difficult to detect and very low frequency. On the other hand, we can use this autoantibody to predict type 1 diabetes and also help in the diagnosis. And from the data from the European patient, we can see that we can see display altered T cell frequency, phenotype, and function. Malaysian type 1 diabetes patients show different autoantibody profile. Therefore, we need more research to investigate the immune mechanism of type 1 diabetes in Malaysian patients. Before I finish, because this is COVID time, so I look up on some literatures and I find out that actually COVID infection can cause diabetic complication in diabetic patient, and also it can induce new onset diabetes in this patient. So it's very interesting area to study as well. So before I finish, I would like to acknowledge my previous supervisor in Finland, our research group members, and deep study investigators and also volunteers where we get the sample from. I would like to acknowledge various funding sources from Finland and also UMPC money that helped me to do meetings, and also our Malaysian collaborators from IMR, specifically Dr. Masita Arif, which is the head of Allergy and Immunology Research Center of IMR, and another collaborator from UPM, Dr. Hasni Mahidin, which is a pathologist, and also type 1 diabetes patients from Malaysia. And that's all from my presentation, and thank you all for your attention. So I'll be more than happy to take any questions. Thank you. Any question?
Yes, Dr. Mahfuz, Fasili here. So, normally when we talk about diabetes, normally we're targeting alpha glucosidase. So I just wondering if you have type 1 and type 2, isn't it? Is it both of type 1, type 2 targeting alpha glucosidase?
That's a good question. I don't have an answer to your question, so I don't know. So I have one question here in the chat box from Dr. Hong. Why type 1 diabetes is related to B40 group and what kind of environmental factors that can contribute to type 1 diabetes? So I mentioned briefly in the, in the Malaysian type 1 diabetes. So why it's related to B40 group? It's because when you don't detect this disease early, the children will develop life-threatening complication. And normally what happens is with B40 group, yes, when you have the disease, because of your economic status, you might not want to go to clinic, let's say, to find out about the diagnosis. Because as a parent, let's say, of a B40 group, you have so many things to do and you have to support yourself. And normally these are people that are on a daily wage. So when you take your children to the clinic or the hospital, you might not be able to work. So the disease will go undetected, and normally this will cause the disease to progress, and you will have the complication develop. So environmental factors, there are so many of them. Again, these studies that I showed to you, these are factors that we know from European or European decent study, or what you call it, Western study. So at the moment, I think we have very limited data on environmental factors related to the Malaysian patient. So one of the things that I want to investigate is look at environmental factors. There's one more question in the chat box saying that, can type 2 diabetes be cured? Basically, diabetes is a metabolic condition. So if you want to cure it, you have to do what you call it, a systematic change. At the moment, I don't know about type 1 type 2 diabetes, but I guess at this stage, it's more important to prevent it from happening than to cure it. So any other question or any more question? Oh, further question from Dr. Hong. What is your opinion on using the assessment on the risk of developing diabetes by using glycoprotein level rather than to detection of autoantibody? Dr. Hong, that's a good question, in which I also don't have an answer to it, because I don't know about the glycoprotein level. And secondly, is detection of autoantibody is easy because you can just take your serum and you can measure autoantibody level. I don't know about glycoprotein level. Even now, even during this COVID time, I believe you may have heard of antibody test. So antibody test is quite easy to do, but I don't know about glycoprotein level. Any more question? So I have a question from Dr. Abu Hasnat Mustafa. As autoantibodies are related to autoimmune disease, is it possible that Malaysians may develop fewer autoimmune disorders as they have low autoantibodies? Okay, this is a good question. Actually, there is, in immunology, there's a theory called hygiene hypothesis. So in hygiene hypothesis, the theory states that when you have a challenge, your immune system is being challenged by infectious disease, your immune system are trained. So you have a better response toward infection or infectious agent. So this is what happened in the underdeveloped countries like in Africa. So in Africa, you see that you don't see so many autoimmune disease, because one of this theory is because your immune system are so trained to fight infectious disease. But as Malaysia is going through urbanization, modernization, the trend that we see now is there are more and more development of autoimmune disease. And from the initial analysis that we perform, based on 2018 data, just now I mentioned that the incidence rate is estimated to be less than 1.5, but from 2018 data, we see that the incidence rate maybe has increased to about 2.5 in 100,000 children. So I think it will be no surprise, because we see more and more this urbanization and modernization, and this is strongly related to the what you call it, the microbiome. We can talk about this in detail. If you want, we can have a coffee over there. I hope I have answered your question, but if I have not, then please feel free to ask the question again. Okay, since there is no further question, thank you all for your time to listen to my talk. You can email me, mahfuz@ump.edu.my, mahfuz@ump.edu.my. I'm more than happy to answer question, or we can discuss research opportunities if you want to. Thank you all, and have a good day. And I wish you Selamat Hari Raya Haji, or Selamat Hari Raya Aidil Adha. Thank you all. Assalamualaikum.